Thank you very much. And I think you have set a beautiful context. And I think as we navigate this discussion, let us also, not view these in isolation, but look at it as a part of the entire ecosystem of interventions which we do as social development professionals. As Bhowmik very rightly put it, just before we came on stage, nutrition in isolation is an issue in India. But nutrition linked to, if we link it to our other programs, education, health, uh, school attendance, it's a humongous problem. So, our esteemed panelists over here bring a wealth of experience with them, and I'll be very happy to traverse this journey of a child along with them. In the spirit of collaboration and shared responsibility, let us look at this as an opportunity to learn from each other, take this forward, and collaborate in these endeavors of nutrition. So, with me today, I have Ms. Pia Arora, who is the Associate Vice President for Diversity, Equity and Inclusion and CSR at Sagility Health. She is responsible for the global DEI and corporate social responsibility strategy for the company across its locations in India, Colombia, Jamaica, the Philippines, and the US. Prior to Sagility, Pia worked with Oracle for 6 years, leading various strategic initiatives, including DEI interventions across the Asia-Pacific region. She has an educational background in political science and international relations, having studied at York University, Canada, and New York University. We also have with us Dr. Kirti Chadha, who is a gold medalist from the AFMC Armed Forces Medical College, Pune, and has 2 decades of rich experience in diagnostics and theranostics. Just correct me if I'm saying it incorrectly. She is currently the Chief Scientific Officer and Group Head of CSR at Metropolis Healthcare. Prior to Metropolis, she was associated with renowned hospitals such as Tata Memorial, PD Hinduja, Sir Gangaram, and other centers of excellence. She has also received a special award for Reflex Conclusive Diagnosis approach, which reduces cost and turnaround time while improving report accuracy. She is on the WHO expert panel for medical devices for cancer and has delivered numerous orations on cancer across the country. Welcome, Dr. Kirti. Well, with more than 27 years of work experience across human resources, industrial relations, safety, security, legal, and CSR, Anu Mehta has worked in several corporate stewardship positions in the automotive as well as the FMCG sector. Anu works with Honda Cars India, and she joined Honda in 2004 as the head of human resources. She has moved ahead and currently is head general affairs at Honda Motors India, where she handles human resources, industrial relations, administration, safety, security, legal, and her calling, as she says, tells me, is CSR. Her current profile as head of CSR involves managing and delivering various CSR programs in the areas of education, health, road safety, and environment. She is a panel member at various associations like SIAM, FICCI, and ASSOCHAM. Welcome, Anuji. And finally, Upahar, the lone warrior over here from with me on the panel. Upahar Pramanik is a seasoned development professional with over 23 years of experience in CSR strategy and has worked with, is currently leading the CSR at the SAR group. He has led and worked across various United Nations agencies, international NGOs, and CSR initiatives. His wealth of experience is in the realm of public health, HIV, reproductive health, nutrition, WASH, as well as youth and women empowerment programs. Upahar has excelled in cultivating and nurturing partnerships across diverse teams of professionals. His commitment to social responsibility and sustainability is evident through his roles as AVP of CSR at SAR Group, as well as in his earlier role as unit head of private sector partnerships at the World Food Programme. So, welcome to all of you. I will try to be a decent moderator, and I'll not take too much time. But you see that clock over there is running very fast. So I will be quick on my questions. I would request you to restrict the answer to around 4 to 5 minutes if possible. So as we saw, nutrition and education, nutrition and health, let's take it in the life cycle approach. Let's look at the entire life cycle of a child. As they enter, the first steps is there. So my first question I'll take to you, Upahar. So taking a life cycle approach to health and nutrition, and also I want you to talk about the clean drinking water as it impacts nutritional status. Can you speak about the access to clean drinking water project that your organization is supporting? I would also like you to mention the experience about working on the first 1,000 days for children, so that we can see the clear linkages between the two. Over to you.
Thank you, Shubhrajyoti. And the context is very well set by Anshu and Bhowmik at the beginning, and by you, Shubhrajyoti, that it is undoubtedly that nutrition is a multidimensional subject, which means that it requires a multidimensional approach. Now, investing in nutrition is definitely going to lead us short-term, long-term, as well as intergenerational outcomes. So I think that's what very well said by you, Shubhrajyoti. So if we look at the life cycle approach that you said, let's break it down to as per age group of 0 to 2 years, 2 to 6 years, 6 to 16, that is your school going program, and then 10 to 19, the adolescent age group, and then look beyond 15 to, up to 49 years of your life. There are various interventions. There's no dearth of programs and designs that is available with us and is on ground. Some of them, as correctly said, the nutrition is not one subject. It is like amalgamation of 15 or 16 or more than that, various dimensions of programs and various aspects to nutritional outcome. Some of them have direct impact, some of them have indirect impact. In the context of WASH program that we support in our as part of our philanthropic support initiatives, based on the idea that WASH has a direct impact on nutritional outcome. And if we look at the WHO, if I quote WHO, 50%, more than 50% of diarrheal diseases and cholera and others actually are attributed to lack of access to safe drinking water and is directly attributed to malnutrition. So in terms of the program that we support, yes, it is branded as an access to safe drinking water program, but it has various components. So let me highlight this 2 or 3 larger component to it. The first is the technology. There's no dearth of technology, but the technology that we are promoting in, or we are supporting to be implemented. Currently, we are working in 4 high burden districts of Orissa in 100 villages in partnership with some hyper-local NGOs as well as local NGOs, looking at a technology that is not too complicated. It is effective, but it is not complicated so that communities can themselves manage, maintain, repair, as well as it is effective in terms of reduction of contamination, in terms of groundwater contamination of heavy metals and various others, and it is also easy to manage and effective to provide the per capita liter of safe drinking water needed 24/7 in the communities. That is one aspect. But the real aspect for which we have been working for 6 years in these villages is community ownership and water governance, where the component of WASH is an integral part. Because creating access to safe drinking water, the work doesn't stop there, it starts from there, and how community takes ownership, decides judicious use of water, reduction in water wastage, wash practices, boiling water during the flood seasons, and various other aspects which are important, in terms of community ownership. Of course, as a part of the sustainability, the community contributes X amount of money. They have village level water committees which are trained on, and they work closely with PRIs to also unlock the money available within the government system to create and implement wash programs, wash drives in the community for a long-term basis. That is what I think is the major outcome which result that we have got out of this investment in this nutrition focused initiative. In terms of the outcomes of that program, yes, the reduction in terms of dodgery, reduction in terms of average time taken by people to get alternate source of water, clean water, has reduced. The incidence of diarrhea actually has reduced in those villages. Water contaminated disease has reduced, which is where, as you all know, that 3 episodes of diarrhea, a borderline SAM or MAM child can fall into a SAM or MAM child, and malnutrition comes back. So although we are doing a third party evaluation currently to actually attribute various other factors, including what we have done in reduction of malnutrition, but this is one. The second part, I know the time is taking, but the second part, very quickly I'll touch upon, Shubhrajyoti, is about the first 1,000 days. Again, in the life cycle approach, any age group that you look at is an important starting point. So, but the first 1,000 days is a critical window. In my personal view, I don't think that if you cross that window, everything is lost. No. It is my personal view. Of course, you have again another window of school program where you can have micronutrient based interventions and even have better nutritional outcome. But yes, the critical aspect, the proven fact is the first 1,000 days, and now as you were talking that day, first 2,000 days is important. So first 1,000 days, 2 programs very quickly, because you said if I have seen transformative, I have seen positive needle moving programs where the frontline worker capacity building as well as food supplementation both works. Frontline worker capacity building, if we look at, I think the real piece where I got associated is the issue around AAA collaboration, and for micro level granular planning, so that you plan better, so that uptake of services is better. We have seen how frontline workers were able to see, determine high-risk pregnancy risk factors and things like that. The second aspect is food supplementation, fortified food supplementation. There are zillions of studies around it which has proven it, but I would still say a combination of both. Yes, education, yes, sensitization, demonstration works, but at the same time, access to food supplementation is also what is very, very critical in the first 1,000 days of life, is what I would say.
Sure, thank you, Upahar. I think that gives us a very clear picture, especially in India, a country which has got a lot of waterborne diseases, how clean water is affecting the health and nutrition status of young children. Let our child grow a bit older, we are moving on from early childhood to children in school. So my second question is to Pia. How do you think mental and physical fitness of children is related to their health? In addition to nutrition, what do you think are the other factors that play in a child's health?
Yeah, thanks for the question, Shubhrajyoti. And, before I answer that, I did want to mention what, Upahar also mentioned and Bhowmik mentioned, that the awareness and sensitization around nutrition is very important. Of course, it goes without saying that access to nutrition for children is very important, but creating that awareness for the children that, if they are going to spend a certain amount of money, are they going to buy something healthy or unhealthy, is also very important. So I think these two aspects are very interrelated. We must keep that in mind. Now, to answer your question, absolutely. Ultimately, we're talking about the health of the children, and mental and physical fitness directly impact, the health of the children. And in fact, research shows that daily physical activity can reduce the risk of non-communicable diseases in children by almost 60%, which is a huge number. So, in one of the projects that we are doing with our implementation partner, is about a structured sports program where training is being provided to these school children and in different sports, and the impact that you see is not just on their physical fitness, but really on their mental fitness as well, mental wellness and their social and emotional skills. So I think it's very important to look at this in a comprehensive manner. And the other aspect is, of course, when these children get this awareness, when they're getting this fitness, physical fitness, they also spread the same awareness within their families, within their communities. So it kind of sets off that virtuous cycle. The last thing is, I think, so in this project, we also have a component of, a sports excellence program. So there's certain children who are really good at sports, any particular sport. They are obviously given the training, but they're also taught about the importance of having the right foods. And so they directly understand that for me to be able to perform better at a certain sport, I also need to eat better. I need to know about what I'm eating. So I think that kind of virtual cycle is very important, and it has ripple effect on the entire community. So, yeah.
Thank you, Pia. I think, yes, I think what attracts children to school is not only the books, but it's the play, it's the way they're able to exercise their bodies, and yes, physical fitness is a very key component to having better nutritional health. Let's get a bit older. We are moving towards adolescence, and this is the age of discovery. Today is the age of the internet, where everybody has access to a lot of information as well as misinformation. But when you see young teenagers, young adolescents, 12, 13 years old, they have a lot of questions in their mind regarding their health, regarding their nutrition, regarding their sexuality. So, Dr. Kirti, could you tell us, about your experience on the role that self-learning and discovery through trusted applications, how have they benefited teenagers, and considering, that the generation has access to too much information today, having good, safe, accurate information, what has been your experience?
Yeah, so to get anything done, if you get into anything, the first thing is about creating a policy around it or relating to a policy around it. Then is the awareness, and then is the delivery. And all these three things become very, very important. Now, everybody does not have to be a CEO or be the Prime Minister or be the government, but you can definitely look at what is the problem. Because whoever in any power has made a policy, he has obviously looked at statistics, has obviously looked at the burden of the problem. And that is why he or she is directing everybody in that direction, right? So, for example, Bhowmik just now shared anemia statistics of his company of just 65 employees, 30%. So I'll share with you, Metropolis's last 4.5 lakh data shows 22.7% people are anemic, right? And most of these are girls and women. And at the same time, another panelist shared that, overeating or not having physical activity causes non-communicable disease right at adolescent. Similarly, it causes anemia also right at adolescent. So 50% of children are actually anemic. So we are in a dilemma where we have half of them who, are eating wrong or are eating much, and other half who are not getting. So when we look at this problem, there is already so many policies, whether we look at the national education policy, whether it starts right from school, or whether we look at the Anemia Mukt Bharat, there are a lot of these things going on. Now, how Metropolis decided to tackle this problem was that let's create more awareness, as rightly mentioned by our moderator, that how do we create more awareness about this? So there are two ways, right? Today, everything has to be omni-channel. If you talk only to a brick and mortar population, you will lose out on the digital population, and vice versa is also true. So we said, let's have an omni-channel approach where we'll obviously partner with NGOs, and Nishta is sitting right here. We have partnered with them also for aspirational districts, Nandurbar, where we are going ahead with the collaboration with them, UNICEF, and the various NGOs, where you can reach people directly. But what about our entire Gen Z, Gen Alpha, whatever you call them, who are all adolescent? And because I have two daughters, one calls herself Gen Z and one calls herself Gen Alpha. Figure out the difference between the two. A lot of difference, just 5 years age gap, but huge generational difference. They don't even see the same apps. right? So we decided that let's have a very powerful digital app, which we have Too Shy to Ask, done by Duru ma'am herself, who was here as the previous panelist. And this gives you pure information right from an expert. Sometimes, when you have time, sneak into your kids' room and see what they're going on. They, as ma'am mentioned, they're going on to various blogging sites where they're getting wrong information, incorrect information. And that's not good, right? So there must be a platform which anybody can download, can have access to, and they will get pure information over there. So Too Shy to Ask app is such an effort of ours, where we have about 2.5 lakh downloads, and we have, a lot of users who are using it actively, and that is now what we want to take to an even higher and deeper height. And the last is about the delivery. See, we can keep on talking about, awareness, but if you don't deliver where the need is, then there is no point of it. So I think that is also very, very important. And that is where, again, you collaborate with either the government or with the NGO, or sometimes directly, like what we did for COVID. So that is where I feel that this has to go. The policy, the awareness, the delivery, all three have to be in sync. If we really want to solve a problem, see the statistics before you intervene, then see the statistics after you intervened. And only data tells the true story. So in only God we trust, otherwise everybody else has to have data. So I think that's how I would put it.
No, wonderful, Dr. Kirti. I mean, I just love that adage which you said, that in God we trust, but everything else needs data. That also reiterates what Upahar was talking, that, it's very important that we measure what we do so that we know the value of the intervention. Speaking of post-adolescence, I think one of the biggest cases for dropout of young girls from the education system is, of course, anemia, as well as menstruation. There is a taboo around it in many communities. There is a lot of misinformation and misconceptions going on. So with that, I would come to Anuji. Anuji, see, it's not the misinformation is one part, but the family and the community play a very key role in motivating young women to go to school. What has been the experiences under Project Swabhiman, which you have done on reproductive and child health, and of course adolescent health also, and how has that experience helped you understand this problem a bit better, Project Swabhiman?
So good afternoon. What I would like to say is, Honda had been doing health camps for the past 18 to 19 years. And when I took over CSR, I started thinking as to health camps were very corrective in nature. Bimar hue, dawai khali, done, right? And we were facilitating that particular thing, right? So, and having been born into a family which was too much, my mother was a very good cook, and some people sitting here can vouch for that as well. So, she used to believe in giving us very healthy food, but tasty food, right? So, it used to, it was always there in my mind as to what should we do in terms of preventive health. Can we keep ourselves fine, right? And what do we do in terms of the villages which are, which have this kind of a problem? So we started off this journey of a project that we launched, which we called Swabhiman, and this was on for adolescent girls and women. And what we did essentially was in 3 parts. So I'll explain the 3 parts to you very in a nutshell. The first part was concentrating on nutrition for girls and women. So when I talk about girls and women, what we did was we did a baseline study. We tried to understand as to what's not working in terms of nutrition. So we, as my previous panelists have talked about, anemia was a big problem. What we did was find out as to what percentage of the population was anemic. And believe you me, 60 to 70% of the population was anemic, mostly ladies and girls. From there, we started off on the nutrition part. So what do we do in nutrition? So we have a nutritionist on our panel who actually helps in preparing very nutritious food from the local food, which is, or local grains, and local vegetables which are available in that particular community. And what she does is, she goes and into the village and makes the ladies actually cook those food, those dishes. And once that is done, then we have created some WhatsApp groups where they do it at their own homes and then they post photographs of the same, right? Anemia, which was approximately, as I said, 67 to 70% of the population was facing that particular problem. When we've hand-holded these women and girls in the last 2.5 years, we've been able to bring it down to 20 to 25%, which means there is a 30 to 35% up in terms of, bringing it up and making them not face the problems of anemia. Now let me talk about what we did on, I'll talk about the major highlights because we don't have time, the clock is not ticking, yeah, it started ticking the moment I said so. Let's talk about menstruation. What we did was, we started off this particular project and we started distributing sanitary napkins. We distribution of napkins for 2 years and then we withdrew. Distribution of napkins. There was a lot of complaint, right, that you're not distributing sanitary napkins anymore. There was a time when we started off this particular project, the sanitary napkins were being used by approximately around 40 to 50% of the ladies and girls in those villages. Today, we brought it to 93% and we're not distributing napkins anymore. That's about menstrual health. So what I will say is, it's all possible. Only thing is that you have to make them understand the relevance of this particular thing. The second thing is that, you have to make them understand that they're responsible for their health. It's not you as NGOs or it's not you as corporates. You'll be there for some time, but then they have to be responsible for their own health. I'll talk about the third aspect that we started off, which was reproductive and child health. We started hand-holding these ladies who were pregnant right from day one, the moment we would understand that they are in the family way. And we have our own community centers in these villages where what we did was, they could come for counseling, they could come and understand as to what they need to eat, what they need to do in terms of having medicines, etc. And we made them also, we got them connected to the primary health centers of the villages, right? We explained to them the benefits of having an institutional delivery rather than getting the delivery done through a DIE. Quite a few of the deliveries were fatal before we took up this particular initiative. Today we are able to save lives of women and many children by making sure that all the deliveries happen in the institutions which is in the primary health center. So we become facilitators, we become the bridge between them and the primary health centers and make sure that they go to the primary health center for delivery. When it comes to nutrition, we handhold them on what needs to be eaten and also make sure that they come back regularly to us in case they are facing any problem during the pregnancy period. So these are some of the initiatives that we have driven. I have talked about 25% of what we are doing, but I think it helps when you actually deep dive into these initiatives, see as to what was not working and then work around them. So that's how it has been, Shubhrajyoti, as far as Swabhiman is concerned.
Thank you, Doctor. I think that's also very true, if we have, if we have healthy mothers, we have healthy babies, it's one of the truest things which you said. Just to continue what you were saying, Dr. Anuji, what has your contribution to, how have you promoted this preventive health along with the government? Because you also work very closely with the local government over there. So what has been your strategy of working with the government and why have you chosen that? Quickly, 2 minutes.
Okay. So we start from the CMO and we work downwards. So what we do is we tell them about our initiatives also and make sure that the government also understands what we are trying to do. Then we have Asha and Anganwadi workers who are there, who are stationed in villages. So what we do is we work hand in hand with them. So we tell them our doctors, in fact in Honda we have doctors. So our doctors are there, and then we have primary health center doctors. So we basically use these doctors and we handhold these Asha and Anganwadi workers in terms of telling them about what is important for them to understand as far as handholding of children, handholding of girls and ladies is concerned. So we make sure that they are able to explain the benefits of government schemes to the villagers, the village women. And our community resource centers also have people who explain these things to them. So if I were to just explain one small thing, there's something called a Mamta card, right? This Mamta card is basically for the women who are pregnant, right? Most of the women in the villages don't even know that there's something like that. And this Mamta card is nothing but, it's a government initiative which has all the information about when you are pregnant, what you need to do, what you need to eat, when you need to get your vaccination done, and what happens, what are the kind of vaccinations which need to be given to your children, once the child is born. So making, connecting them with the health center, and also using the health center to give them this kind of an information. So this is what we do. We collaborate very, it's a equal kind of a collaboration with the government. They help us and we help them when they need us. COVID times, they did not have sanitary napkins. The primary health centers did not have any sanitary napkins. So we facilitated in terms of giving those sanitary napkins to the primary health centers for distribution. That's how we do it.
Awesome. I think it's really wonderful the way you have built synergies, and instead of keeping the community dependent on the Honda ecosystem, we've actually connected them to the larger government ecosystem which has existing facilities. So that's really wonderful to know. Talking about the ecosystem, Upahar, I had a question for you. You have worked on potable water, but do you think, how do you think midday meal and potable water actually impact students' health and their attendance in schools?
Oh, to a great extent, actually. And since you are talking about midday meal, I think it's one of the proven and one of the best examples of an education program with a social determinant. Food and having a means to improving enrollment and retention. It is proven. And whenever we talk about nutrition program, WASH is an integral part of it. Without teaching children about hand washing practices, without ensuring food safety, even if you're talking about centralized kitchen, by the value chain of transportation of food till the time the child consumes it, food safety needs to be taken care of. When we are talking about rural India, even today's date, there are kitchen which means 3 stones. And what kind of food safety we can ensure. So I think WASH and midday meal goes hand in hand. It is not either or situation. However, in midday meal, I think in the context of nutrition investment, Shubhrajyoti, I think it again gives that window of opportunity back again, that micronutrient deficiency or fortified micronutrients food. And I have been part of a project in Orissa where we have seen 20% decrease in anemia because of fortified rice in the midday meal. The second part is also, the WASH practices. If we do not practice, because nutrition is not just about access and availability, it is also about absorption, right? So unless we address the issue of WASH, so I think in all the schools, in midday meal school program, there is the hand washing and other food safety preparation and hygiene issues are integral part, and that is what has been one key learning. One more thing I would also say, what you said about healthy mothers giving rise to, I'm not trying to have a gender heavy discussion here, but certainly there are studies now which are demonstrating that if children have gone to school and have been in the midday meal system, the Z score of the children that they are produced later on in life in terms of height versus age or weight versus height has been better. So I think midday meal is an important program designed and implemented keeping in mind as social determinants.
Thank you, Upar. I think as we were discussing also prior to the session that midday meal is not nutrition only, but it's also a strategy to enhance enrollment and retention of children in school. And I think potable water especially plays a very, very important role in this. So if we look at the entire ecosystem, we say that we're talking over here, but India suffers, India produces a lot of doctors and a lot of this thing, but remote availability of, human resources at the last mile is missing in India. I mean, if any of you have been to deep set villages, you see that we barely get skilled personnel. So my question to Pia is, there's an urgent need for skilled healthcare personnel at the grassroots, in the deep, far-flung areas. So how do you think we can skill or upskill personnel in remote and difficult locations?
Yeah. So I think one way of looking at this is maybe through the lens of sustainability, right? So when we are thinking about our projects, at that point, are we thinking about how the beneficiaries could one day be the trainers, right? So I spoke about the sports training program there. The children that are getting these sports trainings are going ahead and training, right? They are becoming the sports trainers and facilitators. But of course, that's harder when, they are talking about healthcare personnel. But finding those opportunities of, finding the personnel within the communities, I think is the way to go. And second, of course, is technology. That might not be possible in maybe the very remotest of areas, but there are very few areas in India now that, people don't have a smartphone. So I think leveraging technology is something that could really help the situation. Yeah.
Thank you. I think, yes, I think the technology is this thing. So my last question and the most difficult one, I think, Dr. Kirti, is to you, is that the key to better nutrition and health awareness and behavior change. What can be options for schools to enhance awareness and good health and nutrition for children? What could schools do in this aspect?
Yeah, I'd like to take a leaf out of the co-panelist book actually. I think we'll have to create these nutritional ambassadors from within the ecosystem itself, right? And there is a great platform already going on, the Kishori Manch, and that is what, we are trying to work with and partner with. So more and more that we create self-sustainable models and, ambassadors from the ecosystem itself to go back into that ecosystem, right? Because how many people will shift their city or their state or whatever? But the people who are there, they understand. See, for everything, there is always the microenvironment and the main thing. Both the things have to go in parallel. So we can, talk a lot about all this, but we don't know the food practices of that town or that village. So within that, what is a good diet? What is a high protein diet? Whether you talk about a pregnant lady, a lactating lady, or an adolescent girl, or we have so many IVF clinics across the country, right? PCOS is a big problem. One of the biggest causes again is nutrition. So I think the whole thing is in creating more and more nutritional ambassadors from the society to go back to the society. And if we can, train them, empower them, that's why training and teaching becomes very important. Training of teachers, training of students, and I think we have to just take back and give back to the society itself.
Thank you, Dr. Kirti. I think I would like to say a big thank you to all my 4 panelists today, because this is the most nutrition session which I've ever taken, where I don't think I've talked too much about nutrition, but about everything around it and which can support that. And my co-panelists, they have actually supported me in that. So the idea is that we need to look at nutrition in a very different and holistic approach. We can't just focus on food or one aspect of it. And I think each of our panelists over here, Priya, Dr. Kirti, Upahar, and Anuji have contributed significantly in giving us different perspectives to it. I'm sure there would be wonderful takeaways. And with that, I would like to thank all of you, for being here and being parts of making this such a wonderful panel. Thank you. Thank you.